invite the next speaker, Dr. Remya Raghavan, Professor, Sri Gokulam Medical College, for her next talk, Looking Beyond the Typical Unusual Presentations of Optic Neuritis. Over to you.
Good morning, all. My topic is looking beyond the typical. So let us go through two unusual cases of optic neuritis. The first case is about a 51-year-old female who came with sudden loss of vision in both eyes, and that was associated with pain. And on examination, the best corrected visual acuity in the right eye was perception of light, and in the left eye, it was 2/60. Color vision was defective in left eye, and pupils were both dilated and reacting sluggishly to light in both eyes. And fundus showed bilateral optic disc edema associated with hyperemia. So we made a diagnosis of optic neuritis both eyes. She underwent a lot of investigations in the Department of Neurology, including CSF study, serum ACE level, NMO emoji antibodies, paraneoplastic panel, everything was known. MRI brain and orbit showed bilateral, bulky appearing optic nerves with T2 hyperintensity and mild contrast enhancement, suggestive of optic neuritis both eyes. But SCL70 and PMSCL were positive in ANA profile. So these two were the positive reports. So she was put on IV methylprednisolone and then tapering oral prednisolone, and her vision partially improved following this. But after 5 months, she came with a relapse in the right eye with a visual acuity of 2/60, and again another relapse after 8 months in the same eye with a visual acuity of 6/60. So now on examination, the fundus showed bilateral optic disc pallor and arteriolar attenuation. The OCT, you can see that there is superior inferior peripapillary RNFL thinning in the right eye and mild focal RNFL thinning in the infratemporal quadrant, the left eye. MRI brain and orbit showed mild hyperintensity in bilateral optic nerves, BEP prolongation and decreased amplitude. Then repeat NMO and emoji antibodies were negative. The positive result was AMA M2, which was highly positive. She was again put on IV methylprednisolone, and during the follow-up period, her visual acuity became 6/18 in both eyes. So this condition is called chronic relapsing inflammatory optic neuropathy. So this is characterized by its steroid responsiveness as well as its relapsing and or chronic duration. So how do you diagnose this? So there should be a history of optic neuritis with at least one relapse and objective evidence of loss of visual function. Neuromyelitis optica IgG should be negative, and the MRI should show contrast enhancement of acutely inflamed optic nerves. And there will be a response to immunosuppressive treatment and relapse or withdrawal or dose reduction of steroid. So how do you differentiate it from atypical optic neuritis? This is cryon is actually a subtype of atypical optic neuritis, and it is characterized by its relapsing chronic course and high sensitivity to steroid. But the thing is, if you reduce the dose or withdraw the steroid, then there will be a relapse. And aquaporin P4 and emoji antibodies will be negative. So the take-home message is this condition cryon is essentially a disease of exclusion, and it is very difficult to differentiate it from multiple sclerosis, NMO spectrum of disorders, and MOGAD. And patients, though they typically respond to steroids initially, the relapses are common upon withdrawal, and cumulative damage to the optic nerve will be there due to frequent relapses. And some patients, they come with multiple episodes which are refractory to conventional treatment. So they may require more advanced treatment. The second case here, this is about an 11-year-old girl who came with sudden loss of vision associated with pain in the right eye. And on examination, the visual acuity was reduced in that eye, and the optic nerve functions were all defective in that eye. And fundus showed optic disc edema with hyperemia, and you can see the OCT with the peripapillary RNFL thickening. And so we made a diagnosis of optic neuritis right eye for that girl, and MRI brain and orbit showed features of optic neuritis. Flash VEP also showed features of optic neuritis. And we looked for the antibody profile. Anti-aquaporin 4 and NMO IgG were negative, but we got a positive result, that is anti-myelin oligodendrocyte glycoprotein antibody, that is IgG, was strongly positive. So she was put on IV methylprednisolone, followed by oral prednisolone, and after 5 days treatment, the visual acuity became 6/6. Now, This child came with another relapse at 8 months. So here now the left eye was affected. There was defective vision in the left eye, and the optic nerve functions were affected. And the fundus showed optic disc edema with hyperemia, and OCT also showed thickening of peripapillary RNFL. MRA showed thickening of the optic nerve in the left eye, and again she was treated with steroids. And after 1 month, you can see temporal pallor of the optics in the right eye, and left eye looks normal. OCT showed focal peripapillary RNFL thinning in the right eye superiorly, and normal OCT in the left eye. So this condition is called MOGAD-associated optic neuritis. So what is it? So MOGAD is myelin oligodendrocyte glycoprotein antibody-associated disease. So this is an inflammatory disease of the CNS which is characterized by immune-mediated demyelination involving the brain, spinal cord, and optic nerves. So this is common below 18 years of age, and there is no sex predilection. And actually, MOGAD accounts for nearly 50% of acute demyelinating syndromes in children. But the most common manifestation of MOGAD is acute disseminated encephalomyelitis, and the second most common manifestation is optic neuritis. And optic neuritis is mostly it is bilateral and simultaneously bilateral in about 31 to 84%. And most of the patients, they present with another attack of optic neuritis during the follow-up period. And the disease modifying agents which are usually used for treatment of multiple sclerosis may not be that effective in this condition. So the take home message is, unlike MS, the incidence of MOGAD is higher in children, and the most common manifestation of MOGAD is acute disseminated encephalomyelitis, and long-term follow-up and monitoring is needed for potential relapses. Thank you.
Thank you, Dr. Remya, for that excellent presentation.